1 billion people. That is how many people on this planet have migraine. Not a headache, migraine. The second most disabling neurological condition in adults on Earth, and the most disabling in children. Most of them have never had the right questions asked. I'm Dr. Michael. I've been a physician for nearly 30 years, a decade of emergency medicine, intensive care, cardiac surgery, pediatrics, psychiatry. I didn't plan any of it. Someone just suggested medicine to me when I was 16 and I thought, why not? And it's one of the reasons that this channel is called The Accidental Doctor. On this channel, we don't just list symptoms and prescriptions, we slow down. We ask the uncommon questions, the ones that actually change outcomes. Today, those questions are about migraine. Because here's the thing, the usual answer, a triptan medication, a dark room, maybe a referral to a neurologist, is not wrong, but it's answering the wrong question. It's asking, how do I stop this migraine? And I want to ask something different. Why is it happening at all? Stay with me. By the end of this, you will have a framework, evidence-based, referenced and clinically grounded, that most migraine sufferers have never been offered. Let's start with the scale, because I don't think it's properly understood. 1.16 billion people. That number has gone up 58% since 1990. In the UK alone, migraine costs the economy £12 billion a year. And that is not a niche problem, that is a civilizational one. And yet, the standard workup in most GP surgeries, in most neurology departments is rule out red flags, prescribe triptan medications, maybe add a prophylactic, something to prevent the migraine happening, refer on to a specialist if it doesn't settle. In general, nobody checks magnesium, nobody checks omega-3 index, nobody asks about sleep in any useful detail, and nobody takes a homocysteine level. That's just a fancy name for another chemical. I've been in medicine for 30 years. I include myself in some of that criticism as well. Let me show you what I do instead nowadays. Here is the autopilot path in migraine management. Patient comes in, diary of headaches 3, 4, 5 times a month, severe, photophobic means that they are a bit adverse to light, nauseous, and sometimes with an aura, a feeling of something that's about to happen, or lights, or flashing things going on in your vision. You rule out some secondary causes, you diagnose a migraine, you offer a triptan medication, you discuss amitriptyline or topiramate. These are all different medications that can treat a migraine when it starts or try and prevent them happening in the first place. You refer the patient on to a specialist if things are not getting better. Now that pathway is not wrong, it's just very late along the line. It is a fire extinguisher, but I want to know why the building is on fire in the first place. So let's go upstream. When a patient comes to me with a chronic migraine, I do a set of blood tests. There's no such thing as a migraine panel of blood tests. I just check that, by the way. They're just standard tests. They're available everywhere and many patients have never had them done. One of the first that I do is called an omega-3 index. It's not the serum omega-3, it's the index. It actually measures EPA and DHA, which are different types of omega-3 fatty acids, and how they sit inside the red blood cell membranes, because the red blood cells last for 3 months in the body. And so measuring the levels in them gives us an indication of the levels of these important essential fatty acids for a 3-month period. And most people in Western populations sit below 4%, and we want it to be above 8%, which is a good level to have. In 2024, a meta-analysis of over 40 controlled trials, over 6,000 participants found that a high dose of omega-3 produced the largest reduction in migraine frequency and severity of any intervention tested. And that includes medications. High dose omega-3, above 1.5 grams of omega-3 in terms of EPA and DHA per day, and this is what came up on top. Now, I appreciate that fish oil beats migraine drugs is not a headline that sells pharmaceutical conference stands, but there it is. Test the index, don't guess it. Second, magnesium. This is probably the most important thing on the list, and it's also probably the cheapest, which may explain why it's not the most famous. Cortical spreading depression is a fancy term for the electrical wave that propagates across the brain during a migraine, and it's the thing that causes the aura, that triggers the pain cascade. Low magnesium lowers the threshold for that wave to fire. The problem is that standard serum magnesium is not a reliable test for this. You want to test their ionized magnesium or a red blood cell magnesium, and these are not easy tests to come across, but there are other ways of working out whether it's worth giving someone magnesium. In general, most people have a degree of magnesium deficiency, even if their blood test shows that it's normal, and it's very safe to give magnesium. In 2024, there was a meta-analysis of 22 randomized controlled trials which confirmed magnesium supplementation reduces the attack frequency and severity. On a practical note, the formulation matters. Magnesium citrate has the most consistent evidence. Magnesium aspartate hydrochloride has in some trials performed no better than placebo at equivalent doses. So when you're in the health food shop staring at 17 different types of magnesium, citrate is the one. Third, iron and ferritin. Not is it in the range? That question is nearly useless in this context. The question is it optimal? The evidence is strongest in women, and particularly in women with menstruation-related migraines, so migraines that happen around the times of the period. In 2025, a systematic review and a meta-analysis found iron deficiency anemia is associated with a 76% higher risk of chronic headache disorders. The mechanism involves disruption of certain chemicals in the brain, neurotransmitters, dopamine, and also of the sleep architecture. And we'll come back to sleep because I will really not let that one go. Fourth, B12, folate, and homocysteine, all fancy names. Two of them are vitamins from the B vitamin class, and homocysteine is an important chemical that goes up when the B12 and folate are down. And I want to spend a moment on this because it's underappreciated. The evidence is more specific than most people realize, including until I looked into it properly, myself. When B12 or folate are low, homocysteine accumulates, it goes up. And this raised level of homocysteine causes endothelial dysfunction, which means basically that your blood vessels are not working properly. It impairs what's known as nitric oxide regulation, and nitric oxide is an important gas that's produced, and it signals the cells of the blood vessels to open up, to relax. In addition, it increases homocysteic acid, which is a direct metabolite, and that acts as an NMDA receptor agonist. It basically sensitizes the outer layer of the brain called the dura and also the arteries of the brain, and it activates a pain system that basically controls pain to the side of the face and the head, called the trigeminal-vascular system. And that's the system which is at the heart of migraine production. In 2026, there was an updated meta-analysis which confirmed significantly higher homocysteine and lower B12 and folate in migraine patients versus people who did not suffer with migraines. Now, here is where dose matters, and it matters much more than I initially appreciated. Australian researchers ran the key intervention trial. They used 2 milligrams of folic acid, which is 5 times the usual dose, not 400 micrograms. And that's the standard dose you find in most B vitamin complex supplements. They used 2 milligrams. And they also used 25 milligrams of vitamin B6 and 400 micrograms of B12. And at 6 months, migraine disability had dropped from 60% to 30%. That's absolutely dramatic. The follow-up study that used 1 milligram, which was half the dose of the folate, found no significant effect. So the standard supplement at standard doses probably does nothing for migraine, which is a useful thing to know before spending years taking it and wondering why nothing changed. Now, there's also a genetic dimension here. There's a variant called MTHFR, and before you ask, yes, the acronym is unfortunate, and I did not name it. The variant impairs folate metabolism at the enzymatic level. Carriers have chronically elevated levels of homocysteine, that chemical that we mentioned before, even when they're on a normal diet, and it's associated with migraine with aura specifically. And in those patients, we use methylfolate, the active form, to bypass this enzyme impairment. It's a small precision, significant difference intervention. Fifth, vitamin D. Consistent association has been found between vitamin D deficiency and increased migraine burden. And 2026 review of 30 studies, and also another study called a Mendelian randomization study, which can be quite strong, that was done in 2024, showed that the supplementation is strongest in people who are genuinely deficient. So the evidence is best when people actually have vitamin D. So you need to check the level and correct the deficiency where it exists. Basically, if you've got enough, you don't need it. And if you don't have enough, you need it and you should take it. We don't give everyone high doses of vitamin D and call it a migraine treatment. The evidence doesn't support that. And I'm saying this as someone who's been accused of being somewhat over-enthusiastic about vitamin D in the past. Sixth, thyroid. Low levels of thyroid hormone, so basically hypothyroidism, an underfunctioning thyroid gland which sits here in the neck. is a well-recognized and frequently missed migraine amplifier. Checking their TSH alone is not enough. You also need to check the T4 levels. And I have seen migraines that have been treated for years settle once an underactive thyroid was properly addressed. Not always, but enough times that it is now an automatic go-to. Seventh, zinc and a full blood count. Zinc is a cofactor in what's known as GABA and glutamate modulation. Fancy names. Limited but directionally positive trial data. It costs almost nothing to include. You have to be careful about the dosing. You don't want to go too high, no more than, say, 25-30 milligrams a day. So it costs almost nothing to include. Full blood count is a regular blood count, and even mild anemia, which we can see on a full blood count, can destabilize the excitability of the blood vessels that are on the outside of the brain, and it basically means that you've got a frequently more abnormal system of excitability, and that means that it's frequently connected to the headache. So that is the blood, but blood is only a part of the picture, because I said we would come back to sleep. I want to say something that sounds obvious, but it's in practice frequently ignored. Sleep is not a lifestyle factor. Sleep is a neurological restorative process. The threshold for cortical spreading depression drops with sleep deprivation. And you can correct every single blood test I've just described. And if the sleep is broken, you are building on quicksand. So ask about sleep properly. Not do you sleep well, which is one of those questions that sounds useful, and it isn't, because everyone says yes and then admits to 6 hours a night when you push slightly. I ask how many hours you sleep. How consistent across the 7 days of the week? Do you sleep 6 hours in the week and then 10 at the weekend? That pattern is otherwise known as social jet lag, and it's particularly disruptive. Does a person snore? Has anyone watched them breathing in the night? Because here is what is routinely missed. Obstructive sleep apnea is massively underdiagnosed in people who suffer with migraines. In a systematic review in 2024, over 15,000 patients included, it was found that 1 in 6 patients with obstructive sleep apnea has migraine. That's not morning headaches, that's a migraine. And obstructive sleep apnea causes repetitive low levels of oxygen to enter the brain across during the night. It increases carbon dioxide in the brain, and it causes an imbalance and an instability of the automatic nervous system, otherwise known as the autonomic nervous system. And each one of those things is a trigger for migraines in its own right. Treating it with high pressure air overnight through a mask can reduce the migraine frequency, and it can have other positive benefits. Now, I've referred patients for sleep studies who were not even remotely obese, who did not snore loudly, who had never been picked up by routine screening. They often have moderate to severe sleep apnea, which is the inability to get enough oxygen into their bloodstream overnight because of multiple times in which they snore, their airway blocks off somewhat. And once treated, the migraines improved. And some people don't even need a machine like a CPAP machine, which is quite disruptive in many ways. Some people just need to be sleeping on their side, and you can use a trick like putting a tennis ball attached to one side of their back with some tape. And then every time they start turning, they sort of notice it in their sleep and go back, and they're breathing pretty much normally. And then they don't actually suffer with these low oxygen levels. A sleep study is not just for obvious candidates. It's more of a diagnostic tool, and I use it quite a lot. Patients have got mixed feelings about actually having the machine, but their migraines obviously have different feelings about these things. The fundamentals, other things that we need to speak about. Hydration, which is simple. Most patients know that dehydration is a trigger, and people still don't hydrate enough. It's a good idea to have a bottle by your desk when you're working to remind you that you need to drink. Electrolyte balance matters too, not just volume. Caffeine. I've seen people drinking 8 cups a day of coffee go cold turkey, and then the next 3 weeks were really unpleasant for everyone involved. You need to map the caffeine pattern of what you're drinking, and to reduce caffeine, if it's what seems to be one of the problems, you need to taper it off and not sort of jump off a cliff. Alcohol is a vasodilator. It means it opens up the blood vessels, it relaxes them, and it also causes dehydration, and it also disrupts people's sleep. Red wine adds histamine, which is the chemical involved in allergic reactions, and also tyramine. And I'm not saying don't drink anything. I'm saying know what it does and document it, and know how to incorporate it into your life in better ways, and probably with much less than what you're already drinking and less frequently. Now, There's some more interesting territory. Blood pressure medications as migraine preventers. There's a class of blood pressure medications that are called ACE inhibitors and angiotensin receptor blockers, or ARBs, and they have genuine randomized controlled trial evidence for migraine prevention, independent of any blood pressure effect. This is not widely known, and honestly, I didn't know it until too long ago. Lisinopril is one of them. It's an ACE inhibitor. It's been shown in randomized crossover trial in 2001 to reduce migraines by about 1.5 days a month. Candesartan is an ARB, and it's got an even stronger trail. It showed 32 to 46% of patients with more than 50% reduction in migraine days. And there was a trial in 2025 in which the reduction per month was about 2 days versus 0.8 days per month for placebo. So we're close to 2.5 times difference. The mechanism involves the renin-angiotensin system, which has got, it's related to kidney function, and also something called the CGRP pathway. And these are not first-line migraine agents. They have their own considerations. But if a patient has migraine and high blood pressure, there's a way of killing two birds with one stone. You have one medication, it both treats the migraines or prevents them somewhat, and it can treat the blood pressure. And there is solid evidence for them both. So from a medical point of view, that's quite elegant. What is CGRP? Well, you may have seen some advertising for newer migraine medications targeting CGRP. They work, they are a genuine advance. CGRP is otherwise known as calcitonin gene-related peptide. It's a vasodilator. It opens up the blood vessels, and it causes, which normally causes pain signaling to be released into the trigeminal nerve during a migraine, and that causes the headaches. Now, the new drugs actually block this from happening, and they're very effective. But I want you to sit with one question. Why is CGRP being chronically over-triggered? Well, the drivers are inflammation of the brain, or in the brain, neuroinflammation as it's known as, sleep deprivation, estrogen withdrawal, magnesium deficiency, chronic physiological stress, everything we've been talking about over this last 10 minutes or so. The medications are excellent, but they don't address what is upstream of them, and that is not a criticism of the medication. It is just an observation that if you're only working at the bottom of the waterfall, you haven't changed the flow of the river above it. Hormones, particularly in women. Estrogen withdrawal is one of the most important and potent identified CGRP triggers. It's the mechanism behind migraines that happen with the menstrual cycle. The drop in estrogen in the luteal phase, which is somewhere around the middle of this cycle, triggers the cascade directly. And it's also the mechanism behind perimenopausal migraines. So people who are going through a menopause who start having migraines, which frequently arrives as a new or worsening problem. And it's puzzling to patients who have never had migraines before. Women who've been told you just have migraines without any conversation about their hormonal pattern, their cycle, their contraception, where they are in the menopause transition, are not getting a full assessment. Full stop. Vitamin B2, otherwise known as riboflavin. Here is something that costs almost nothing. It has moderate to good evidence. It's endorsed by the American Academy of Neurology, and it's prescribed almost approximately never. Vitamin B2 is given at 400 milligrams per day, and the hypothesis is that migraine in susceptible individuals involves impaired metabolism of mitochondrial energy, which are the very small powerhouses, let's say, inside the cells, and they are important in the brain's power supply, which becomes less efficient under certain conditions. And that lowers the threshold for migraine attacks. And riboflavin supports the mitochondrial electron transport chain. It basically means that energy production is flowing much more smoothly. There was an original trial in Neurology, the journal, in 1998, which found about 60% people responded to 400 milligrams versus 15% for people who were not given that dose. And that was also followed up in further meta-analysis. There is one side effect worth mentioning about this. Your urine will turn a remarkable shade of yellow, and I mean genuinely alarming. If you're not expecting it, it's harmless, but you should know about it. Tell patients in advance, or they will convince you, they'll ring you convinced something has gone badly wrong. That's my experience with that. Coenzyme Q10, same mitochondrial hypothesis. In 2023, a large study had a meta-analysis, and 2024 there was a review in Nutrients, and both confirmed improvement in migraine frequency and duration. Smaller evidence based than riboflavin, but a consistent direction, and they're often used together. Safe, more expensive than riboflavin, which maintains the tradition of better evidence thing being cheaper. So the upstream principle, let's bring this all together. Over 1 billion people around the world, the second most disabled neurological condition on earth, and the average migraine consultation in a typical GP surgery is 8 to 10 minutes, which is long enough to confirm the diagnosis, issue a prescription, and move on. Nobody has run an omega-3 index test in that time, not necessarily checked magnesium in any meaningful way, no one's checked homocysteine, nobody's thought about sleep apnea necessarily, and we haven't connected the migraine pattern to the hormonal cycle or tried things like riboflavin. And I want to be very clear here, I did not always ask all of these questions either. It's not a lecture from a perfect clinician over here. This is about 30 years of gradually learning what autopilot medicine misses. People really deserve better in this condition. What I think actually needs to happen, and what I try to do, is that when a patient comes to see me with chronic migraines, I have a framework. Blood work, omega-3 index, magnesium, iron, B12, folate, homocysteine, vitamin D, thyroid, TSH, free T4, zinc, full blood count. And in people who've got aura with their migraines, the test for the MTHFR is worth considering, and methylfolate if the variant is confirmed. Supplements that can be used: magnesium citrate, riboflavin with a warning about the urine, which I now give automatically, coenzyme Q10, B complex at the doses that actually have evidence, 2 milligrams of folic acid and not 400 micrograms, and sleep, taking a proper history, sleep study if there's any suggestion of apnea, and we should treat that as biology and not as a lifestyle. For women who are going through hormonal changes, or they are having migraines related to their periods, their hormones may need to be checked. They need to be mapped about the frequency that these things are happening and the timing within the period. Those questions need to be asked, and some of those patients may need to see a gynecologist as well, or an endocrinologist who's a specialist in hormones. Medications where co-indications exist, so such things as I said before, the ACE inhibitor, the ARB blockers, they have compelling RCT support. And running through all of it, hydration, caffeine pattern, alcohol pattern, sleep consistency every time. And then we look at what's left. What's left is where the triptans live, where the CGRP inhibitors live. You may need these drugs. You may need considerably less of them than you needed before if those other factors have been now corrected. But either way, you will know about the right questions having been asked. That is uncommon sense medicine. It's not rejecting guidelines. It's not dismissing pharmacology. It's just asking the questions that belong upstream to the prescription. If you found this useful, please leave a comment below. Tell me if this reflects your experience or if it doesn't. Tell me what I've missed. There will be something. 30 years in, there is always something. And if you know someone who has been managing migraine for years and never had these conversations, share this. It costs nothing. I'm Dr. Michael. This is The Accidental Doctor, where we practice uncommon sense medicine. Ciao for now. Stay well, and I hope to see you very soon.